Assalamu alaikum. I am Dr. Soal Hadi, Professor of Microbiology and Immunology. And our lecture today will be about antimicrobial agents. We will talk about antibiotic complications, antibiotic resistance, and stewardship programs. Intended learning object, our ILOs. By end of our lecture, we must be able to first, discuss the complications of antimicrobial agents. Second, describe different mechanisms which involved in antimicrobial drug resistance. Third, recognize the importance of antibiotic stewardship program in healthcare facilities. And at the end, we must be able to identify the principle of optimizing the use of antibiotics. Complication of antibiotics. Use of antibiotics may be associated with different types of complications, which may be superinfection, drug toxicity, allergy, hypersensitivity, and development of drug resistance. Superinfection. Use of antibiotic may be associated with superinfection. This occurs in patient which is admitted in hospital with excessive use of antibiotic, which allows the overgrowth of a type of normal flora, which is a drug resistance member, and may be potentially pathogenic and cause a disease. Like overgrowth of candida, which may lead to oral thrush and vulvovaginitis. Also, patient which is admitted in hospital and especially in ICU with excessive use of a type of antibiotic like clindamycin may be associated with infection with a type of organism which is Cholesteresia difficile, causes pseudomembranous colitis or antibiotic associated colitis. Second form of complication associated with use of antibiotic is drug toxicity, where certain type of antibiotic may be associated with drug toxicity, with overdosage or prolonged use of such a drug may lead to toxic effect on the host. These types of drugs are potentially toxic, especially if they are administered to children, pregnant women, and old age. For example, tetracycline when given to a pregnant woman or to a child below 8 years, it may be associated with permanent staining of the teeth. From examples which causes drug toxicity, as we told, tetracycline, which causes a permanent staining of the teeth if it is given to a pregnant woman or to a very young child below 8 years old. Also, streptomycin is toxic to the 8th cranial nerve and may lead to deafness. Chloramphenicol may cause bone marrow depression and great baby syndrome. Aminoglycosides may cause nephrotoxicity, and polymyxins may associated with neurological and nephrological complications and causes nephrotoxic and neurotoxic effect. Another form of complication associated with use of antimicrobial agents are allergy, hypersensitivity. Certain type of antimicrobial agents may be associated with hypersensitivity reaction or allergy, where it acts as a hapten. This hapten binds to the tissue protein and lead to stimulate an exaggeration and exaggerated immune response, and this lead to tissue damage, which is hypersensitivity. May vary from a simple type of tissue damage or hypersensitivity or severe form of hypersensitivity. For example, penicillin can cause allergic reaction, which may be simple form of reaction in the form of urticaria, or may be a severe form of reaction in the form of anaphylactic shock. Also, sulfonamide. Local application of sulfonamide may lead to contact dermatitis. Another form of complication associated with use of antimicrobial agent is development of drug resistance, which is a very important problem we face it today. Antibiotic resistance, a global problem faced today in treatment of infectious disease. Hospital-acquired infections are more likely to be caused by antibiotic resistance organism. It's more likely to be infected with antibiotic resistance organism more than community-acquired infection. Antibiotic resistance organisms are common in hospital setting. Why? This occurs due to widespread antibiotic use in the hospital, which select for these types of resistance organisms. Also, hospital strains are often resistant to multiple antibiotics. And this resistance usually due to acquisition of a plasmid carrying gene. This plasmid carrying several genes that encoding the enzyme which mediate resistance. When exposure to bacteria occurs, infection occurs, and the bacteria start to spread and cause a disease, which need to be treated using the drug, which is antibiotic or antimicrobial agents, and then the drug used for treatment. In non-resistant cases of bacteria, when bacteria enter, the bacteria start to multiply, and then when we use this type of antimicrobial agent, which is the bacteria is sensitive to it, bacteria will die and the person become healthy again. But if these types of organism is resistant to these types of antimicrobial agent which is used, and this carried on a gene, on a gene carried on the plasmid. When the bacteria enter, start to multiply, and we use the antibiotic which is resistance, the bacteria continue to spread, and the person remain sick, and there is no response to this type of antimicrobial agent. This is a resistance to antimicrobial agents. How antibiotic resistance occurs? First, loss of bacteria, which is a few are drug resistance, enter the body. This blue form is a type of bacteria which is sensitive and the normal flora, which is a good type of bacteria protecting our body. And in the red color, it is a type of bacteria which is a pathogenic form of bacteria causes a disease. When the patient uses antibiotic will kill the bacteria which is causing the illness, and in the same time, it will kill also the good bacteria which is protect the body from infection, which is the blue form. And remain this red bacteria, which is a drug resistance bacteria. And now it become alone and allow overgrowth, and it grow and it take over. Also, some types of bacteria give their drug resistance to other bacteria, which causes more problems. Resistance to antibiotic is one of the most important problems which faces the doctors, and it needs more research for a new form or new types of drugs used to treat this patient. Where now we have the patient which has infection with an organism with multiple drug resistance, and there is no any choice for treatment. There is no antibiotic which is suitable for treat it, as this type of microorganism is resistant to most types of antimicrobial agents, which is a very big problem. The origin of antibiotic resistance could be due to non-genetic or genetic origin. So we need to talk about causes of antibiotic resistance and talk in details about the origin of antibiotic resistance. Origin of antibiotic resistance. Origin of resistance may be genetic or non-genetic. Genetic origin may be a natural origin or acquired. Acquired genetic origin of antibiotic resistance may be due to chromosomal mutation, plasmid acquisition, or transposon acquisition. Non-genetic origin of resistance may be due to, first, metabolic inactivity of the organism, for example, in case of Mycobacterium tuberculosis. Second, may be due to loss of a target structure, as in protoplast, or may be due to wrong drug, wrong dose, or failure to reach to appropriate size for the action of antimicrobial drugs. Non-genetic origin of resistance. Number 1, metabolic inactivity of the organism. The antimicrobial drug to act on the microorganism and causing killing or inhibition of it, this microorganism must be actively replicating. So, active replication of bacteria is required for most types of antimicrobial drug action. If the bacteria is metabolically inactive, this means it will be resistant to this type of antimicrobial drug. For example, Mycobacterium tuberculosis. Mycobacterium tuberculosis can remain dominant in tissue for many years in latent tuberculosis, during which it becomes insensitive to the drug, where the drug acts on it need it to be actively metabolically, and it is now inactive. In case that the host defense are lowered or patient become immunocompromised and the bacteria begin to multiply again, they become again sensitive or susceptible to the drugs, which indicating that genetic change didn't occur. It's just change in the metabolically activity of the organism. When the organism is metabolically actively, it means that sensitive to the antibiotic. And when the organism is inactive, it means it is resistance to the antimicrobial agent. From non-genetic origin, number 2, loss of a target structure of the drug. Certain organisms would ordinarily be killed by penicillin, where penicillin can act on the cell membrane. It acts on by inhibition of peptidoglycan, which is found in the cell wall. When these bacteria lose their cell wall and survive as protoplast, it becomes insensitive to these types of the drug which act on the cell wall, which is penicillin. Later on, if such organism can resynthesize the cell wall and has a cell wall, it becomes again susceptible to this drug. Other factor of non-genetic origin of resistance, which makes the organism appear to resistance to antibiotic, is administration of wrong dose wrong drug, wrong dose, or failure of the drug to reach its appropriate sites in the body. From non-genetic origin of resistance, it's a natural resistance, or intrinsic inheritant resistance. Intrinsic resistance is an innate ability of the bacterial species to become resistant or to resist activity of a particular type of antimicrobial agent. This may be through inherent structural or may be functional characteristics without any barrier exposure to these types of the drug. So it has no need to be previously exposed to these types of the drug. It's a natural or inherited. From the examples of natural resistance to antimicrobial drug, certain type of organisms which lacks the target for the antibiotic, as occurs in mycoplasma. Mycoplasma lacks the cell wall on which penicillin acts, where penicillin acting by inhibition the synthesis of peptidoglycan which is present in the cell wall. When mycoplasma has no cell wall, so this organism lacks the target for the antibiotic and it becomes resistant to penicillin. My example is mycoplasma, which is resistant to penicillin. Another example is inaccessibility of certain drugs into the cell wall. This occurs as in case of gram-negative bacteria, which is resistant to vancomycin. This resistance may be due to inability of the vancomycin to penetrate the outer membrane and reach inside the cell. Another example of innate or natural resistance is production of enzymes that inactivate the drug. For example, in Klebsiella species, which is resistant to ampicillin due to production of enzymes, which is a beta-lactamase enzyme. This enzyme destroys ampicillin before the drug can reach the penicillin binding protein targets. We still talk about non-genetic origin of antimicrobial resistance, which is acquired resistance. Most of the drug resistance bacteria occurs as a result of genetic change, which is an acquired genetic change, which may be chromosomal mediated resistance, which occur as a result of spontaneous mutation in the gene. That gene controls the sensitivity or susceptibility of the organism to the given drug. And this will result in change in the structural receptor for the drug. So the antimicrobial drugs cannot attach to its specific receptors on the organism. For example, resistance of streptomycin, which occurs due to change in the receptor located in 3 subunits of bacterial ribosome. Acquired resistance may be due to plasmid or transposon-mediated resistance, where resistance occurs through a plasmid or through a transposon. For example, R factor, which is resistance factor, with a class of plasmid that carry a gene. This gene for resistance may be to one or more or several antimicrobial drugs. This plasmid gene usually codes for enzyme, where this enzyme are able to destroy antimicrobial drug. For example, beta-lactamase enzyme, which destroys the beta-lactam ring in the penicillin and cephalosporins. These enzymes are encoded by plasmid gene in which it acquires R factor. Antimicrobial resistance gene of the plasmid can be transferred from one bacteria to another. Transfer through the bacteria may occur by one of the three methods: transduction, transformation, and conjugation. Different factors may enhance the development of bacterial resistance, where the selection of bacterial resistance enhanced by one of the following. Number one, may be due to low dose of antibiotic, where low dose of antibiotic were described, and this has no effect on the microorganism. It only leads to development of bacterial resistance to this type of antimicrobial drug. Also, use of antibiotic in certain cases which is self-limited infection and no need for antibiotic. It's non-indicated. It will be self-limited without any use of antibiotic. In this case, we use the antibiotic and causes development of antimicrobial resistance. Third, prescribed unnecessary long course, or in case of interrupted course of antibiotic therapy. Certain patients use antibiotic for 30 days, 1, 2, 3 days, and on the fourth day he started to feel with improvement and he stopped using or complete the course of antibiotic. This will develop antimicrobial resistance. Also, inappropriate and indiscriminated use of the drug, which is misuse of antimicrobial drug. Antimicrobial drug must be described according to culture and safety. We must detect the type of microorganism and detect to which antibiotic this organism is sensitive. Then we prescribe the sensitive and the most suitable type of antimicrobial drug. This resistant microorganism will overgrow, where the antimicrobial drug causes inhibition of the normal flora, which is already present, which is a useful type of microorganism, and cause overgrowth of the microorganism which is resistant. And it will replace the original population of normal flora. Mechanism of resistance of microorganisms to antibiotics. There are several mechanisms for resistance of antimicrobial drugs of the organism to antimicrobial drugs. It may be due to, first, the microorganism produce an enzyme which destroys the active drug. For example, beta-lactamase or penicillinase, which is produced by staphylococci and can destroy penicillin and cephalosporins. Also, chloramphenicol resistance may be due to the production of certain enzyme, which is acetyltransferase enzyme, which destroy the drug and causes inactivating chloramphenicol by acetylation. Other enzymes as adenylases enzyme, phosphorylases, and acetyltransferase. These enzymes causes inactivating of aminoglycoside by adenylation, phosphorylation, or acetylation. And all of these enzymes causes destroy of the active drug and inhibit the effect of it, and the microorganism become resistant to this type of antimicrobial drug. These types of resistance are of genetic origin, and it is of plasmid mediated. Also, certain type of microorganism as gram-negative organism can produce an enzyme which is a beta-lactamase enzyme. It's called ESPL, or extended spectrum beta-lactamases, which are newly described enzyme arised by mutation in the gene for the common plasmid-mediated beta-lactamases. ESPL produced by gram-negative bacilli, and they transfer resistance to penicillin, cephalosporins, monobactam, and azithromycin. as the true name. As we show the enzymes which present inside the cell in yellow color, the bacterial cell secretes these types of enzymes which act on the antibiotic in purple color and causes inactivating of this antibiotic and present its effect on the microorganism. So the bacteria produce enzyme which destroy or inactivate the antibiotic. Second mechanism of resistance, microorganisms change their permeability to the drug, and this occurs by modification of the purine protein present in the outer membrane, and this will affect and reduce the uptake of the drug and cause impairment in the active transport of the drug into the cell. For example, amikacin and tetracycline. And these types of resistance is of genetic origin and it is plasmid mediated. Microorganisms change their permeability to the drug. This occurs by modification of the protein, which is a purine protein present in the outer membrane, and those cause impairment for active transport into the cell, where the bacteria produce altered protein. This protein blocks the passage of the antibiotic through the outer membrane to reach inside the cell and acting on the cell. This occurs in gram-negative bacteria, as in case of tetracycline, amikacin, and the polymyxin. Third mechanism of antimicrobial resistance is microorganisms develop an altered structure target receptor for the drug, where it is of genetic origin and occurs due to chromosomal mutations, as in case of resistance to aminoglycosides, which is associated with alternation of the 30S subunit of the ribosome. Also, methicillin and oxacillin resistance occurs due to alternation of the penicillin binding protein, which is enzyme involved in peptidoglycan biosynthesis. And resistance to quinolones developed due to alternation in the DNA gyrase. And resistance to rifampicin, which is developed due to alternation in the RNA polymerase. And these types of alternation or resistance is of genetic origin and occurs due to chromosomal mutation. Microorganisms develop an altered structural target receptors for the drug. These receptors or target site receptor may be a ribosomal subunit or may be an enzyme or others. Alternation in the target site receptors relate to reduce or block of the binding of antibiotic, as shown in these pictures where the altered ribosomal subunit in green colors block the effect of antibiotics or block binding of the antibiotics, prevent binding of these ribosomal receptors to the antibiotic and prevent the action of antibiotic on the microorganism. Another mechanism of resistance to antimicrobial drug occurs due to development of an altered metabolic pathway. This altered metabolic pathway will bypass the reaction which is inhibited by the drug. This occurs due to chromosomal mutation. For example, bacteria which is resistant to sulfonamide. As we know, sulfonamide acting as an analog for para-amino benzoic acids. It acts by competitive inhibition to para-amino benzoic acids, which is essential metabolically for many organisms and involved in the synthesis of folic acid, which is important precursor for the synthesis of nucleic acid. So when sulfonamide acts by competitive inhibition of para-amino benzoic acids, causes inhibition for synthesis of folic acid. The microorganisms start to cause a resistance, develop resistance to sulfonamide by change the pathway, alter the metabolic pathway, capable for using already preformed folic acid, and so don't require for the synthesis of folic acid in the form of para-amino benzoic acid. Another mechanism is active efflux pump ejection, where active export of the drug out of the cell. The drug will export or eject, the cell will reject or export the drug outside it, which is a plasmid mediated, where certain protein present in the plasma membrane of gram-negative bacteria, this protein acts as a pump, which will eject or expel the antibiotic and prevent them from reaching its active site or reach inside the bacteria and reach its effective concentration. This occurs because of resistance to tetracycline, sulfonamides, and quinolones. Bacteria produce new transport protein. This new transporter will pump the antibiotic out of the bacteria and cause active export of the drug out of the cell by this type of bacteria protein present in the cell, in the plasma membrane, which is present in gram-negative bacilli, act as a pump that expel the antibiotic and prevent them from reaching its effective concentration. Antibiotic stewardship program. There is a link between unnecessary use or overuse of antibiotic and the incidence or emergence of antibiotic resistance bacteria. It was found that it's not possible for completely eliminate this evolutionary phenomena, which is antibiotic resistance, which is resistance to multiple drugs. But it can be slowed or even modified. This occurs by optimizing the use of antibiotics. This need to implement a specific program, which is an antibiotic stewardship program, which must be implemented in our healthcare facilities, including hospitals, primary healthcare centers, or ambulatory healthcare centers. Improving the use of antibiotics is an important patient safety and also public health issue. It is both national and global priority. What is the antibiotic stewardship program? Antibiotic stewardship program is a program used to control the use of antibiotic. It involves timely and optimal selection of the antibiotic for the proper adjustment of its dose, route of administration, and duration for the best clinical outcome of the treatment, which is therapy, therapeutic use of antibiotic, or prophylactic for prevention of infection. So it controls time, optimum selection of antibiotic, and it adjusts dose, route of administration, and duration in both therapeutic use of antibiotic and prophylactic use of antibiotics to prevent infection. Why antibiotic stewardship program is important? Why it is necessary? Antibiotic stewardship program has an important role where it increases the frequency of correct antibiotic prescribed for both therapeutic purpose and for prophylactic use. Also may decrease, retard, or even inhibit the emergence of multiple drug resistance organisms. This program can help doctors to improve the quality of the care and improve patient safety. This occurs through increase in infection care rates. Also, antibiotic stewardship program make better use of resources. This occurs by using cheaper drugs where possible. There is certain good practices for optimizing antibiotic use, which include consider whether or not the patient actually requires this antibiotic. Use only the antibiotic when patient is in need for this antibiotic. If it is required, give him. And if there is no any requirement, it's very important to stop using antibiotic. Avoid treating colonized patients who are not actually infected. So we treat infection and not colonization. We must be sure that the patient has an infected wound or infected site of infection. There is an organism and has a susceptibility for a specific type of antibiotic to start use of antibiotic. Don't change antibiotic therapy if the clinical condition is improvement, where we use at first empirical type of antibiotic. And then when the result of the sensitivity appear, don't change this type of antibiotic if there is improvement. Only change it and start with another type of antibiotic if there is no improvement. If there is no clinical response occur within 72 hours and with the clinical diagnosis, the choice of antibiotic or the possibility of a secondary infection should be considered. So if there is no improvement within 72 hours, we start to show what is the problem. There is another infection, there's a secondary infection occurs, or there's a false choice of antibiotic and we need to change it. We must give the antibiotic for the minimum length of time that's effective. Shorter is better. Long use of antibiotic is not useful for the patient. It will be effective in a proper time. And short time is better than long time. More use of antibiotic, more susceptibility for development of antimicrobial resistance. Also, the duration of antibiotic therapy must be reviewed after 5 days. After 5 days, we start to show if the patient still need to use antibiotic or not, or stop it. So use the pharmacy stop policies, which means that the drug are written up for a specific or specified period and only continued if a new prescription is issued. If there is no new prescription, there is no use for the antibiotic again, and it will be stopped. This is a stop policy for taken by a clinical pharmacy. In case surgical prophylaxis, you must give only one dose, which is 1 to 2 hours before the surgery or on the table of the surgery, and continued if indicated for a maximum 24 hours. No need for antibiotic 3 or 4 days before or after the surgery. It's only on the table or 1 to 2 hours before the surgery, and in some cases if needed, complete for 24 hours only. Summary for some important points in our lecture. This is an important slide to show in summary the mechanism of antimicrobial resistance, where the antibiotic develop resistance or microorganism develop resistance type of antibiotic by different mechanisms, which may be inactivation by adding a phosphate group on the antibiotic, which can reduce its ability to bind to the bacterial ribosome, maybe due to impermeability by modification of the cell wall protein, maybe modification through a modified drug target, or maybe bump or reflex out by increasing the active efflux of the drug. Thank you.